Okay, we're not in safety if we don't know how to adapt in real time. Good morning, I'm Patricia McGaffigan. I work at the Institute for Healthcare Improvement, and I am the substitute for Dr. Jerry Hickson, who was unable to be with us today. He sends his regrets, and I'm going to talk to you a little bit about what IHI is doing in the world of safety that is not necessarily specific to medication safety or opioid safety, but is clearly relevant to safety. So with that, let's kick in a little bit and get started. We're at 40 years of the Anesthesia Patient Safety Foundation. As we come into the fall this year, we are also at 33 years, I think, for the founding of the Institute for Healthcare Improvement by Dr. Don Berwick. And we are 25 years into the publication of To Err Is Human and the aftermath of the impact of that report, which many of us are very familiar with and talk about quite frequently. And one of the most important aspects of this report was identifying the fact that humans are fallible. And yet, at the same time, and amid all of the recommendations of To Err Is Human, I think it's fair to ask ourselves, is the progress that we've made transformational, adequately transformational and sustainable in safety? And over many years between the National Patient Safety Foundation, where I worked before the merger with the Institute for Healthcare Improvement, we've pulled together expert panels to examine what's getting in the way of the transformational progress that we know that we need to achieve, despite many pockets of excellence and, quite frankly, the leadership in the anesthesia community of the Anesthesia Patient Safety Foundation. So what we're really seeing, and the short story here is related to a quote from W. Edwards Deming that talks about how a bad system will get in the way of a good person every time. And what I'm going to talk to you today is what we're doing in IHI to help move the shift in the direction to be able to think about how we improve systems that have the impact that supports our advancement in safety across the many challenges that we've been dealing with. And I'm not going to go into detail on this slide, but these are some of the examples of the shift that we're really focusing in on in our work at IHI, from thinking about safety as something that we have because we have a grade on our website, to recognizing that safety is an emergent property of the system, a real-time reality of the system. And while what we've done in the past can serve as an indicator for where we might be in the future, it is not necessarily any guarantee, as you know, because it's what we're doing in each and every moment of our work that determines whether and how we're safe. We spend a lot of time measuring and reacting to errors after harm occurs and really trying to focus on fixing people in the process, with a far less proportionate investment in the intentional design of systems that proactively identify and mitigate risk, and co-engineering those systems with the expertise that we once had a lot of in the aftermath of the publication of To Err Is Human, with human factors experts and safety scientists and systems engineers who helped us create worlds that were safer. We've spent a lot of time trying to constrain human variation, which is necessary when we think about the importance of standardization in our work, and we've already spoken about that today. Yet we've got a high degree of whole system variation in how organizations are structured and how they're supportive of safety, and how they're intentionally designed, and how they use humans as assets versus liability, and how they ensure that safety is the responsibility of all and that everyone is held accountable for it. Similarly, we've had a lot of focus on physical harm for patients and families, very much appropriately so. And at the same time as we looked at our evolving definitions of harm, we're looking at physical harm, non-physical psychological harms, inequities as harms, and also recognizing something that APS is very much focused in on, which is the safety and the well-being of the healthcare workforce. We've also talked about, high reliability organizations, which everywhere we go, everywhere I go in my travels, folks say we're a high reliability organization. And we ask for, how is that so? So we've trained everybody on high reliability and the 5 principles, yet high reliability organizations as a noun is probably more of myth than recognizing that high reliability organizing is the day-to-day work of organizations. And finally, we're spending a lot of important time measuring and reporting on culture and not necessarily ensuring that we are continuously improving the cultures in which we operate, and recognizing signals and cues, such as whether or not reporting rates have changed, and recognizing that decreases in reporting may not be the signal that we're looking for. Looking at variation and workarounds, and instead of recognizing those as important cues that something in the system may not be working well, we tend to point our fingers at the individuals and say there's something wrong with them, without taking an equal look at the system itself. So let me talk about how this is coming alive in 3 areas at the IHI. The first is through the National Action Plan, the Safer Together National Action Plan. The second is through some work that we've done and partnered with some of our federal agencies on, that is introducing some new measures that are coming very soon to an acute care hospital near you. And I'm going to talk for a moment about certification. The Safer Together National Action Plan was something that was envisioned by our board of directors, of which, by the way, Dr. Hickson is chair. And it was the first time that in this country, we had really convened a large number of organizations to come together and collaborate on a national action plan for safety. In fact, at the outset, there were 27 organizations. There are many more now. They include groups like ISMP and the FDA, 6 federal agencies in total: American Hospital Association, the American Nurses Association, the Joint Accreditation, and I'd be remiss if I didn't emphasize the important contributions that our patient and family partners have made in this work. Instead of focusing on any specific challenge in patient safety, we focused on what was challenging about the ecosystem that we could work on, and the 4 areas of the National Action Plan that are foundational to this work are areas that we have referenced, I think, in several cases so far today, and we'll be talking about through the duration of this conference: culture, leadership, and governance, meaningful patient and family engagement, workforce safety and well-being, and the learning system. And across these areas, we embedded several principles, 3 of which are on the slides here today. They include ensuring that our work would be very much person-centered on patients and families and the workforce. Secondly, that what we developed would be relevant in all care settings across the continuum. And third, the inextricable relationship between patient safety and equity, with the recognition that inequities are harms. There are 3 components to the National Action Plan, and many of the organizations in this country and outside of the country, quite frankly, are using the National Action Plan to be able to identify opportunities for improvement in the foundational areas that we talked about, and again, that are inextricably linked to whether and how safety challenges such as medication errors come into play. There's the National Action Plan itself. There's an online self-assessment that organizations are using. Actually, I think hundreds of organizations right now are pulling together core teams with an executive sponsor and various representatives from across the organization to really get a handle on the current state. And one of the most important, I think, stimulus that this has provided are conversations that are not necessarily happening in organizations, where a CEO, for example, might think that all is well and good when it comes to patient and family engagement, and others in the group are saying, hey, we're not necessarily legends that you think we might be. We've got great opportunities for improvement. And then there's an implementation resource guide, and all of these are freely available on the IHI website. This is an example of culture, leadership, and governance from the organizational assessment tool. I just want to point out what I referenced just a moment ago. In the left-hand side, 2 of the 7 categories for culture, leadership, and governance include job descriptions and annual reviews. And as you move from left to right and you advance to higher levels of scores, organizations are assessing whether or not the job descriptions of all senior leaders, applicable to all senior leaders as well as trustees, are integrating safety, into the job descriptions, and whether or not in those annual reviews that is being taken into consideration. There's a lot of fine print on here, but again, I just wanted to call that out because organizations will say, we've never had this conversation in the history of our organization. Second area, how many of you are familiar with the new structural measures that are headed our way? Okay, this is probably something we could spend a lot of time on. If you were working in an acute care hospital that is subject to the CMS inpatient prospective payment system and or the 11 cancer hospitals, effective this year, there are 2 new structural measures that are coming into place that are about patient safety and about age-friendly care. And I know that both of these considerations are highly relevant for the anesthesia community. They're largely informed by the efforts that we and our partners have had in creating the National Action Plan and the age-friendly framework. And the short story is that in the applicable hospitals for this year, starting in January, calendar year 2025, hospitals are obligated to report on how they're performing across both of these measures. In 2026, the scores will be publicly reported on the Care Compare website, and in fiscal year 27, hospitals that fail to report will be subject to financial penalties. So my appreciation is similar to what I just saw when I asked how many were familiar with this. These are measures that folks are generally not familiar with, but again, are coming very, very soon. The patient safety structural measure has 5 domains that are really reflecting whether and how organizations have implemented some of the evidence-based and more salient processes associated with culture and leadership in organizations. These are, again, foundational processes and activities that are very much aligned with the National Action Plan's foundational areas. And the 5 domains of the patient safety structural measure are on this slide, focusing again on whether or not there's leadership commitment, how safety is evident in strategic planning and organizational policies, culture of safety and learning health systems, accountability and transparency, and whether or not there's activities that reflect meaningful engagement of patients and families in this work. This is just an example of one of the domains under strategic planning and organizational policy. Again, it's an eye chart, but there are things here that are very, very inextricably linked to safe systems and medication safety that are on this list. And you can see the same under culture and safety and learning health systems. And the same is true for age-friendly care, whereas, you know, the 4 M's, medications, what matters to patients, mobility and mentation are all evident in that process. So with that, I just wanted to close down and also note that building competencies in the workforce is an important part of what we do. The Certified Professional in Patient Safety credential is now held by over 7,000 people across 32 countries, many of whom are from the anesthesia community. And we have just about certified 1,000 third-year medical students at the Texas College of Osteopathic Medicine. Dr. Jonathan Cohen is actually one of our faculty for their review course, and he's with us today. And we'll be introducing human factors in healthcare and age-friendly certification exams in the next year. Sorry, Nat.
You're actually fine for time. Don't rush.
Oh, now you tell me.
Now, but I have a question.
Okay, and I also wanted to just note, you know, with the emerging, you know, interest and fascination and the intense involvement with artificial intelligence or augmented intelligence, we have a new report from the Lucian Leap Institute that resulted from an expert panel that we did back in January that has a range of recommendations related to patient safety for groups like developers, healthcare leaders, clinicians, patients and family advocates, and patient safety and quality colleagues, and an upcoming second part webinar. We did one 2 weeks ago that's on our website on how AI may impact the work of patient safety professionals, and this is all presented by our co-chairs, Dr. Bob Wachter and Dr. Kaveh Shoshanya, who have made an indelible mark, I think, on where we're headed with the use of technology in healthcare. And with that, Nat, I will concede and turn things over to you.
Well, actually, if you'd stay. Thank you so much. If you stay at the podium, I have one question. We're in good shape for time. I've known you over maybe 15 years in various different roles, including here at the Seaport in the National Patient Safety Foundation, working with Teja Algandi. And I wonder if you could do two things. One is explain the overlapping Venn diagrams of NPSF, the Lucian Leap Institute, the IHI, and how we as an audience of safety people would know which organization to connect to in certain domains, and also maybe just describe your own career journey through those organizations.
And you wanted really to end on time. Okay, so that's a great question about, what are the entities that we're talking about? As many of you know, the National Patient Safety Foundation was founded in 1997. So after the IHI's founding in, I think it was 1991. Ultimately, and Jeff Cooper's a fabulous historian on this too, because he was central to the core work in the board of National Patient Safety Foundation, because we were across the river from one another in Cambridge and Boston ultimately, and because we were kind of running into each other at so many conferences and in so many committees, and we had a lot of similar pieces of work. There was a decision to merge the organizations in 2017. I came from NPSF. We kept both brands, the brands of NPSF and IHI, as many organizations like the ones you're working in tend to do when there are mergers. And ultimately now we all fall under IHI. With incredible legacy and I think honor to the work of the National Patient Safety Foundation, which includes the Lucian Leap Institute that was founded in 2007, co-chaired by Dr. Lucian Leap. The Lucian Leap Institute continues its work. It's a program of the Institute for Healthcare Improvement. And we are heavily focused, I actually serve as senior sponsor for the Institute. We're heavily focused on setting the compass for the future of safety and taking on new challenges and opportunities such as artificial intelligence. And now we're going to switch. No?
I'm going to keep pressing it. We're in the city of Boston, and I think it might be useful to at least mention Betsy Lehman's name, the year it happened, and how it impacted this city's energy around patient safety, and why it's so exciting to be here.
Okay, we didn't prepare for all of this, but I'm happy to share what I know. I think it was 1992. Betsy Lehman was a very, very popular columnist for the Boston Globe, who was being treated at the Dana-Farber Cancer Center and experienced, you probably know this better than I do, a substantial overdose that resulted in Betsy Lehman's death. There was this cataclysmic impact, I think, in the Boston area, and many of you are from the area, may have some interesting reflections as well, that really kind of put patient safety on the map. It kind of moved from, we had Tueris Human in 1999, but this was kind of the starting point, I think, for public recognition in this broad community here. And as a result of the strong visibility that Betsy Lehman had, there was an investment by the state of Massachusetts in the Betsy Lehman Center, which continues its wonderful state-funded work. We partner with them regularly and sit on a number of committees together to be able to address safety in Massachusetts. 2 years ago, the Betsy Lehman Center released a roadmap for patient safety in the state of Massachusetts, very, very similar. And I think one of the nice things about the work is the alignment between the roadmap for patient safety in Massachusetts with what I shared with you about the National Action Plan that was issued a couple of years prior, very, very similar to the work that's going on with the patient safety structural measures and the PCAST report, which was issued last September, that is on the president's desk right now. And we're not sure where that's going. We know this is not a good time to be sitting on the president's desk, but I have hope because they've recently assigned a good colleague from the Agency for Healthcare and Research to the Office of Science and Technology of the President. And we may be hearing in the next few weeks if there'll be a related hearing and event in DC that coincides with World Patient Safety Day on September 17th. Now, I think that's enough.
Okay. Thank you, and God bless you for all the work that you've done.